one very special guest, Dr. Navneeta Sasikumar, and she is a clinical associate professor, pediatric cardiology, Amrita Hospital, Kochi. I have kept her to speak later because I am particularly all ears to her. My son is an adult CHD, and she is closely associated with adult CHD and post-pandemic, pre-pandemic, all those things, what changes they have to bring about in their lifestyles, what we are looking at, and the need for follow-ups, because most of the people have lost contact with their hospitals. Even I couldn't get back to my hospital because of the pandemic. So we are all worried, like, what is it that is in store if you do not have a proper follow-up strategy, or we miss the follow-up. So I would really request Dr. Navneeta Sasikumar to speak on this topic. Hello, ma'am.
Thank you all for having me here. So good afternoon, everybody, and it is such a great pleasure to be here and an honor. Thank you again for the invitation. And so today it was great listening to the talks and the discussions, especially the one on insurance by Smita ma'am. It's good to know that there are opportunities and avenues which can be explored in the future. So I will be focusing on follow-up care of congenital heart disease patients. During the talk, I will be referring to some medical terms and some of the problems that congenital heart disease patients could encounter on follow-up. Please be assured that the only intention is that knowledge is power, and knowing things will help us to deal with things better. So, if any of the matter that I'm presenting is concerning or worrying to any of you, please reach out to us. And we are always there to help you out with your queries, whether it is related to medical, personal, social, financial, whatever. So it's just a disclaimer in the beginning, because when you talk about follow-up, I will be forced to talk about a little bit of medical conditions. So to start with, yes, I would say that the sky is the limit, and this man is one of the best examples for that. This Sean White, who is an Olympic gold medalist for snowboarding, actually. He's been operated thrice for tetralogy of Fallot and pulmonary atresia. So first surgery and then conduit replacement. So, the gist of the story is, yes, there will be hospital visits, there will be multiple procedures, but still, there's no stopping life if you really want to go at it. So coming to the topic, I would say that care for congenital heart diseases is a continuum. It starts with recognition, then a proper diagnosis, and triage of who needs emergency surgeries or procedures and who can wait, referring the patient to appropriate center, for procedures or surgeries. And an important part of it is transport, especially critically sick babies. And then comes the actual treatment part. And the coldest part of all is follow-up. Okay, the treatment is done, and now is the coldest part of all. And at the same time, that is the part where most of these patients would be spending most of their time in. So the active part occupies less of the time. But then, when we say follow-up, we are looking at a lifetime perspective, what happens to these children as they grow up, as they become older, what are the problems that they could face medically, as well as socially, personally, and all, and how can we help these children as they go through it throughout their lifetime. So, when we talk about follow-up, the first thing that comes to our mind is who needs follow-up and when do they need follow-up. So, what I would like to point out is that even if two patients have the same diagnosis and they've undergone the same treatment, ultimately no two patients are the same. The names of the diagnosis would be the same, the names of the procedures would be the same, but no two patients are ever the same. Each patient is unique. You all know it better than me. And each patient has a history of their own. And that is what makes professionals like me interested in this and hooked to you patients and trying to do as much as possible to help you all. It's actually a great privilege for us to be part of your stories. Each of you are different. Each of you have different anatomies, and each of these patients will have different physiology, and accordingly, their needs will be different. So The timing of follow-up and who all needs follow-up will also be different based on this. So one important thing that has come in the last few years is in giving importance to both the anatomy as well as the physiology. So there might be two patients operated for ventricular septal defect, for example. One of them might have absolutely no residual shunt, no pulmonary hypertension, the lung pressure is normal, nothing, they're on regular follow-up. There is no major or active physiological problem going on at that point of time. But another operated patient with a ventricular septal defect might have some other associated issue, like a pulmonary hypertension, or on follow-up, they might develop some new issues. So even if the baseline anatomy is the same, they can go through varying stages of physiology. So based on this, what frequency of follow-up is needed will also change. So this is quite useful because, as I said, sometimes the long-term issues that we come across might be directly related to the disease itself, but sometimes it might be unrelated. Like some of you might be aware that the aorta, which is the biggest blood vessel in the body, which carries blood from the left-sided pumping chamber to the whole of the body, actually. So this aorta can enlarge in some type of congenital heart disease, even after operation. So it can happen in a variety of diseases, actually. It can happen even in patients with simple, like bicuspid aortic valve. It can happen in operated patients with tetralogy of Fallot. So this aortic enlargement has nothing to do with the actual underlying disease, but then that is something which we will focus while on follow-up. So some points that we need to be looked up on follow-up might be directly related, some might not be directly related. Also, I would say that as we move across the lifespan, patients will move from one class to another. Like, bicuspid aortic valve being followed up, underwent one balloon dilatation for a narrowing of the valve supposedly, and it was well relieved, and the patient was on follow-up over 5 years, 10 years. There is a small possibility that it can occur again. And when the stenosis or the narrowing worsens again, they move across classes. So the physiology changes. And we need to track that change in physiology and intervene at the right time. Too early interventions are never good. Too late interventions are never good. So that is exactly why we need regular follow-up, so that we can track the changes in physiology and decide on what needs to be done at the right time. It should never be early. It should never be late. So that timing can be ideally appropriately done only when patients are on regular follow-up. And so regarding follow-up, you all know that, as children, the follow-up has to be done by a pediatric cardiologist, and it is best done in centers where we have support for complex congenital cardiac surgery, anesthesia, post-operative care, facilities for interventions, including advanced interventions and cardiac imaging as well. As we move across life into adults, as we grow up into adults, we need more people and more specialists around to take care of these children as they grow up into adults. So the role of fetal cardiology was beautifully explained by Dr. Maniram, because especially congenital heart disease patients, when they conceive, when they are giving birth to their children, they have a slightly higher incidence of congenital heart disease compared to the general population. So it is good to have fetal cardiac service. And when adult congenital heart disease patients go through pregnancy, based on their physiological stage, most of them, or at least a significant proportion of them, will fall into the high risk obstetric category, where we need support from obstetricians who are experienced in handling such pregnancies, with the support or with input from adult congenital cardiologists at each point in pregnancy. Also, as they grow, some of them will have problems with pulmonary hypertension, and it is important to have services of specialists in pulmonary hypertension as well. So as they become adults, they continue to be followed up. They need more and more specialists working in coordination to help through each of their stages. Not only cardiac diseases, but on follow-up, like in the COVID times, we all know that, if during the COVID times, we know that COVID itself, although if you compare the number of children who are affected by COVID and the number of children whose hearts are affected by COVID, it's only a small percentage. But when it gets affected, sometimes it can get very serious. So, sometimes non-cardiac disease can affect the heart, and at that time you'll need support from the cardiologist to help them tide over that. And suppose suppose a congenital heart disease patient develops a surgical, like an appendicitis or anything of that sort, and then when the question comes about general surgery and anesthesia, an input from the pediatric cardiologist or the adult congenital cardiologist is necessary for safely performing anesthesia as well as surgery in these patients. And more important is when it comes to pre-marriage counseling for men as well as women who are survivors of congenital heart disease. When it comes to contraception, because not all methods of contraception can be utilized in congenital heart disease patients. Some of them have their own advantages, some of them have their disadvantages. So each patient is different. And when it comes to contraception, an in-depth discussion with the cardiologist as to what method is most appropriate for this particular patient is important. Pre-pregnancy counseling, that is another area where follow-up plays an important role, because some of the medications that a patient might be taking might not be advisable to be continued during pregnancy. So we might need changes in medication. And as I already mentioned, if there are residual lesions, or if there are physiologically significant lesions or like pulmonary hypertension or new onset arrhythmias, any of these sort, managing those pregnancies, needs a little bit more attention and care compared to those without. So an adult congenital heart disease patient with pregnancy is best managed in a center where we have obstetricians who are experienced in handling high-risk pregnancies, supported by a team of cardiologists who are experts in each of the subspecialties in cardiology, which includes electrophysiology, sometimes pulmonary hypertension, in addition to the adult congenital heart disease specialist. And as Dr. Maniram already discussed, there is a recurrence risk in children, and this is one aspect which we would like to consider. It's different across different PhDs. It varies whether it's the mom or the dad which is affected. So discussion regarding that and how to plan the pregnancy, the recurrence risk, and planning the pregnancy according to that is also very important. And I would also like to mention that, when you look at adult congenital heart disease in India or in Kerala, we do not have much data. So I would like to bring to your attention that we are trying to collect some data through this study, which is called the Approach International Study. So this, we have started at Amrita. It is an international study, including 80 centers across the world. And what we are looking at essentially is the quality of life of adult congenital heart disease patients, completely from a patient's perspective. So it is all questionnaire based, and we are looking at the patient's perspective of the medical, personal, social, and financial issues that they are going through. And what this study aims is to collect data which we do not have as of now, and consolidate this data and use it for changes in policy, both from the medical as well as as Smita ma'am was referring to, from a policy point of view, insurance, social support, all that. So this, we are hoping that would be a major step forward supporting adult congenital heart disease patients. And then another thing that I would like to bring to your notice is that in the recent years, there have been multiple studies which looked at cardiovascular risk, which means, the coronary artery disease, which blockages in arteries, or what predisposes to stroke in adult patients, older patients. So there has been some studies which point that when congenital heart disease patients grow up, these group of patients compared to general population, they have a slightly higher risk of contracting or having these diseases as adults. So it is important that we follow healthy lifestyle, because these are preventable. That is the most important thing. So these stuff are, unlike congenital heart disease, which is not in our control to a great extent, except for the pre-implantation genetic diagnosis that Dr. Maniram was referring to. So mostly it is not within our control, but the cardiovascular diseases in the adult, which includes coronary artery disease, stroke, heart failure relating to these. So these are preventable to a great extent. So if we know that our congenital heart disease patients are at higher risk for these when they grow up, we can institute preventive measures at the right time, even if they develop like risk factors for these, like hypertension or diabetes, dyslipidemia. We can treat it aggressively so that we can prevent complications from developing later in life. And so this is one thing which, this is another aspect of why congenital heart disease patients need to be on regular follow-up with specialists who know, like over lifetime, what problems they can develop and how we can address them. So what influences the development of these is an interesting area of research, and hopefully by the end of this year, we'll be getting into some research for in that area as well. So is it the stress of the procedures or and the interventions, or is it the timing of the procedures, stressful procedures as a neonate, as an infant, or is it psychosocial factors which predispose them to this cardiovascular diseases in the congenital heart disease population as they grow older is unknown as of now. And this is another area of potential research we will be taking up in the coming years as well. So thank you all for your patient listening, and I'm very happy to take questions if any.